Coming to another very common cause, pulmonary embolism. Very common, often goes undiagnosed because patient just basically presents with breathlessness. X-ray may or may not show something. Patient will be hypoxic. You will keep wondering what happened, and they will not give you much time. So the first thing that you can see in the emergency room is actually the ECG changes which happen. So it has very classical ECG changes, which we call S1T3Q3, which is in lead 1, they will have a wide S wave. In lead 3, they will have a presence of a Q wave along with an inverted T wave, which basically actually signifies right heart strain, but it may sometimes point towards the possibility of pulmonary embolism. The first thing you need to do is put these patients on oxygen. CT pulmonary angiography is usually the diagnostic test. And once you've picked up PE, you have to treat it with blood thinners. So that's how you treat PE. It is more common in people who are bedridden because of clots in their leg veins or pelvic veins, and can also happen in people who have certain inflammatory or vasculitic diseases, very commonly seen in them. In people post hip fractures or long bone fractures, in people who are even in pregnant women, it's very common. They may present to you with classically shortness of breath, will have low oxygen, may or may not have chest pain, may have history of feeling faint or lightheaded. Those are things that may or may not be present. We've discussed the diagnosis. In very rare cases, when there is a pulmonary infarction along with pulmonary embolism, you may get a triangular wedge-shaped opacity with the base towards the pleural surface, which basically indicates a pulmonary infarction. So you may sometimes be able to see this opacity, may not be able to pick it up, but CT pulmonary angiogram remains the gold standard of diagnosis. But if it's not possible, you may also get a lung perfusion scan. Treatment, like I discussed, is supportive, of course, with oxygen, anticoagulation. Sometimes if there is a lot of clots in the lower leg veins, which you pick up on the Doppler, you may need to get an inferior vena cava filter installed. And sometimes if in severe or very severe embolism where the load is very high, you may even have to instill thrombolytic therapy. So, but in the emergency, it's important that you have a high suspicion for pulmonary embolism and, of course, maintain oxygenation. You will also sometimes get these patients who have lung cancer, who are diagnosed cases of lung cancer, who may come to the emergency room, very often maybe with hemoptysis, chest pain, cough, breathing difficulty, hoarseness. These are problems that they commonly come with. Of course, you have to treat them symptomatically, make them comfortable, and also rule out at the same time pulmonary embolism, again, very common in people who have malignancies, and pneumothorax, pleural effusions, and such things which can actually be treated well. So the other thing is, of course, tension pneumothorax that you will very often see in the emergency. We'll talk about it. It is basically a condition that results when air is trapped in the pleural space between the visceral and the parietal pleura under positive pressure, displacing mediastinal structures and compromising the cardiopulmonary function. These people will have chest pain, they will be breathless, they may have low oxygen levels, and at the same time, they can have low blood pressure. This is a classical X-ray of how a tension pneumothorax looks. So if you see, this is actually the tension pneumothorax is on the right side. If you see the lung is completely compressed, so much so that there is completely air occupying the right hemithorax, and so much so that it is practically actually pushing the mediastinal structures also in the opposite direction, hence compromising even the left lung and, of course, the cardiac output. Treatment is very simple. In the emergency room, all you can do is put in a wide bore needle in the second intercostal space in the mid-clavicular line and maintain it with an underwater seal. It will give immediate relief to the patient. In the meanwhile, you can arrange for an ICD insertion, which is usually done by the either the intensivist, a pulmonologist, a thoracic cardiothoracic surgeon, an intervention radiologist, or such. The causes can certainly be iatrogenic. In the emergency room, you will have non-iatrogenic causes, which could be blunt trauma, it could be rib fracture, it could very common again in people who are divers or mountaineers or pilots. And of course, any other pneumothorax, when not treated in time, it can also lead to tension pneumothorax. So I would just like to conclude by saying that pulmonary infectious emergencies are responsible for significant morbidity and mortality and frequently require treatment in the ICU. Early aggressive diagnosis and treatment is hence required to effectively control these emergencies, and sometimes you can actually be saving